Good afternoon, everyone, and welcome. My name is Kat Martins, and I am DWDC's Program Specialist. Today, I'm joined by my colleagues Amanda Coventry-Barrage and Kelsey Goforth. We would like to begin by acknowledging that the land on which we gather here today is the traditional territory of the Wendat, the Anishinaabe, Haudenosaunee, Métis, and the Mississaugas of the Credit First Nation. These nations continue to experience ongoing colonization and displacement. Today, Toronto is covered under Treaty 13 and the Williams Treaties. Dying with Dignity Canada is also mindful of broken treaties that occurred across Turtle Island and recognize our responsibilities as treaty people to engage in a continuous process of truth and reconciliation with all people across this land. I am thrilled to welcome you today. Through our webinars, we aim to provide you with information and key takeaways, as well as create a space for conversation on end-of-life topics alongside the professionals that know it best. Before we welcome today's speaker, I'd like to go over a few housekeeping items. Everyone on the call today is muted. However, there will be opportunities to submit questions. To do so, please type your questions into the question bar on the Zoom side panel, and we will read it out for you at the end. Please try to keep your questions as concise and clear as possible. While we are going to try to get to as many audience questions as possible, unfortunately, we may not get to everyone. If you have any outstanding questions or questions that are personal in nature, please email us at support@dyingwithdignity.ca and we will follow up. This session is going to be recorded, so no need to take any notes. There will be a post-webinar survey that will pop up on your screen after the webinar and will give you the opportunity to share your feedback. We are also accepting registration for an upcoming series of our Death Dialogues program, so please enter your information in the post-webinar survey if you're interested. And now to introduce today's speaker. Sarah Yip is a clinical nurse specialist working in palliative care at North York General Hospital. She has a master's in clinical nursing from the University of Toronto and specialty certification in hospice palliative care nursing with the Canadian Nurses Association. In her work, Sarah has provided palliative care consultation and end-of-life care for patients and families in hospital. She is currently enrolled at the University of Toronto, completing her nurse practitioner diploma. Thank you so much to our speaker for joining us today, and now I'm going to pass it off to Amanda to get us started with the interview.
All right, thank you so much, Kat, and thank you, Sarah, for joining us. Let's go ahead and get started right ahead with our interview questions. So first question, let's start with some basic ideas. Firstly, what is a clinical nurse specialist and how does someone become trained as a clinical nurse specialist?
Thank you, Amanda, and thank you, Kat, for the introduction. It's a great question because I think a lot of people are not familiar with the term clinical nurse specialist. So essentially, a clinical nurse specialist is a registered nurse who's gone back to do additional training, whether that's a master's degree or a doctorate degree, and they also have some form of specialty in nursing. So for myself, that's in palliative care.
All right, thank you so much for that. Next question, what inspired you to enter the field or specialize in palliative care?
So I did the first half of my career in intensive care, and I love critical care nursing, but I also saw a lot of really difficult end of life. And through those experiences, I was looking for something else in my practice, looking for a way to meet patients and their families earlier on in their illness trajectory. And this actually prompted me to go back to school in general. I did not know what I was looking for at the time. And when I went to do my master's, I found palliative care, or sometimes I think maybe it found me. And it was just that click, that kind of realization that this is the kind of nursing I feel like I was meant to do. And it's really given me the privilege of being able to spend time with patients and families in a different way, speaking with them earlier on, and really getting to form connections to walk people's journeys with them.
Thank you so much for sharing. You know, for this follow-up question, we talk about your transition from intensive care to where you are now. Can we talk about, you know, in your new field, so to speak, what does a typical day look like for you?
So I've done a couple different roles in palliative care. Right now I'm working in a hospital, so I'm doing what we call consult care. So a typical day looks like spending probably about half my time doing clinical work. So in the hospital, I meet people during their admission for any type of palliative care needs. And I'm going to give a little bit of plug about what is palliative care, because I think there's a lot of misconceptions about this. Sometimes people think palliative care is just end-of-life care. And I know that sounds funny given the title of today's webinar, because I know we're here to talk about end-of-life care. But really, palliative care is an approach that looks at quality of life for people with a serious illness at any stage during that illness. So I very commonly meet people at the start of their diagnosis, and in hospital, sometimes even before they have a diagnosis, palliative care can be involved. We're really here to help with symptom management, helping people have conversations about what's important to them. But of course, a big part of what we do is also being there all throughout the journey, including the end. So end-of-life care is a big part of my job. This is just my plug to say it's not the only part. So don't assume or don't kind of get afraid if you hear, oh, palliative care has been involved. That doesn't necessarily mean it's at end of life.
Wonderful. Thank you for making that distinction.
In addition to the clinical work I do, I also do a lot of education and policy work, things within the organization to support the delivery of palliative care.
Thank you. And we just touched on the clinical work that you provide as well. So how can someone connect with palliative care? Is that just through a referral system? When they visit, intensive care in hospital, can they get connected right there, for example?
I wish there was like a simple answer to this question, but it is going to be very system dependent depending on where you are. I know people are joining from across the country, but essentially palliative care can be provided anywhere. And it really depends on where somebody's at in their journey in terms of what kind of supports are available to you. So for example, there's palliative care in the hospital, which is the work that I do. There's palliative care in the community, which I used to do before I came to this role. So having teams come into the house. A palliative approach to care can be provided in long-term care settings, in people's retirement homes. There are palliative care units or hospices all across the country as well that are really focused on providing symptom management at the end of people's life. So there's a whole big spectrum. I should also mention there's clinics that people can go to. But again, it's really going to be dependent on what your area is. So I encourage people to connect with their primary healthcare providers to ask those questions. What are my options to connect with palliative care teams? Who's in my area? What do those supports look like?
Thank you so much. All right. For our next set of questions, we're going to focus a bit more on patient navigation at end of life, and specifically in hospital. And we talked a little bit about the misconception of palliative care being end of life care or hospice care. So I'll start with this question of what are some of the common misconceptions about end of life care in hospital?
I find when I meet people, the number one question they have for me is, what are my options for care? What's it going to look like if it's in hospital, or where could I go from here? And so I see my role as really helping to provide people with a roadmap of their care. So what does it look like to live with, for example, heart failure or dementia or cancer? And where are we in that journey for you? And this allows us to kind of help plan ahead in terms of thinking of what I might expect with this illness, how much time we're talking about, where do I think you're going to find the most supports for your care, and really helping people to plan ahead that way.
All right. Thank you for that. And, we talked a little bit about that roadmap and the types of care that might be most important given their diagnosis, their trajectory. And this follow-up question is about the needs in patient navigation. So I ask, what are the most common patient navigation needs that you hear about? What are the most common types of care that they request?
So I often find that people sometimes don't know that you're allowed to say no to treatments. And that might sound a little bit funny, but acute care or hospital settings have a way of sucking you in, and then it just becomes one treatment after the next, and you get stuck on almost a roller coaster. And I've met people who will tell me, I wish I didn't have to come back to hospital, or I wish it didn't have to be like this. I don't want to go through another test. I don't want to live like this, or this isn't quality of life to me anymore. And, sometimes it just takes that kind of timeout conversation to say, is the care we're providing actually in line with what your wishes are and what you're hoping for? And if it's not, let's come back and readdress that plan, come up with a new plan, because you don't have to keep coming back to hospital if that's not what you want. And if these tests and these treatments are no longer matching your wishes, we need to come up with a different treatment plan so that we're not doing things to you, but we're doing things for you. So it's really trying to find a plan that matches the medical situation, but also matches patient wishes. And I think it's important to have those opportunities to take a step back, not get too caught up in the day-to-day of things happening, and refocus on what is the bigger goal here.
Absolutely. To ask a follow-up question about these kinds of conversations about treatment to versus what's the ideal trajectory of care. Who's typically involved in a conversation like that? Is it just the patient, or can that also incorporate things like caregivers or loved ones?
I always encourage families to be involved in conversations. When I meet people, one of the first questions I usually ask is, who do you want to be involved in this conversation? And sometimes people want to have that opportunity for a one-on-one and be able to ask all their questions first. But then the follow-up would always be, who else do we need to include in these conversations? Because nobody exists in a vacuum or by themselves, right? And if we're making a plan, I want to make sure, who are all the people that could be impacted by this plan? And let's involve them so we can hear from them too. Because so often it's not just the person who's in the bed that I'm meeting, it's the whole family and the caregivers who are looking after them. So if somebody wants family and caregivers to be involved, we try to have conversations all together. And it's also an entire interdisciplinary team too. All of medicine, but especially palliative care, is not just provided by one person. I could not do this work without the palliative care physicians I work with, the social workers, physiotherapy, occupational therapy. There are many different players here that allow this work to be done.
All right, thank you for that. Next question. How do healthcare providers ensure there is culturally appropriate care being provided to the patient and their loved ones?
So the only way you can do this is to ask, essentially, because you can never assume that you know what somebody's cultural beliefs might be or their religious beliefs might be. I've met people who are even in the same family, in the same culture, in the same religion, but have different ideas about how they want that to look in their care or what kind of role they want that to play. So it's just simply asking, tell me what is important to you in your care, and how do we make sure we honor those wishes where we can. I find this a lot in end of life when we talk about religious or spiritual needs and trying to figure out what is important to people. And that might look like having the priest come in or having that last conversation with their rabbi and seeing how we can really enhance those opportunities. But we won't know if we don't ask. But if your team's not asking you, it's also really important that you share those wishes with your healthcare team.
Wonderful. Thank you. Next question. This is a bit of an open-ended one. What tips or advice do you have for people who are navigating end-of-life care in hospital and in general?
Mm-hmm. So there's this really great podcast that I'm not sure if people have heard about. It's called the Revolution Waiting Room. And it's a really great guide designed for patients, actually, who are living with a serious illness, to empower you about different things you can think about along this journey of illness, and different things you might ask your healthcare provider. So I would encourage anyone to take a look at that take a listen to that podcast. They also have a book that's called Plan for the Best, or Hope for the Best and Plan for the Rest, which I really like as well. And I think there's a saying that they use that's really helpful for me. It's this concept of walking two roads, right? So one road being hoping for the best outcome or being positive and optimistic, and the other road being, what if things don't go the way we hope, or that kind of worst case scenario planning. And being able to keep a foot in both roads is a really helpful tip I would give to anybody who's in the hospital or living with serious illness. I sometimes meet people who are very, very sick and who tell me, I'm not in a place where I can talk about these things right now because I just want to be hopeful. I want to hope for a miracle. And I can certainly appreciate that. I too want to hope for a miracle with you. But I also worry that sometimes if we lose that opportunity for a discussion early on, we actually miss the boat completely. And things can change so quickly, and there no longer is time to talk about it. I sometimes think about palliative care the way you might think of insurance. I know that sounds a little bit funny, but you get insurance, whether that's for your car or for your house, not because you think or are planning for something bad to happen. You don't plan to get into a car accident, but you get it because just in case something happens, you want to have a plan. You want to have someone that you call, someone who will help take care of you for the next steps. And that's a lot of what palliative care is like, is that we are too hoping for the best, but just in case, let's start a conversation about what it might look like so that we make sure that we are always respecting your wishes and values.
Couldn't put it better myself. Thank you. All right. For next question, is there anything people can do while healthy to be able to more effectively navigate the healthcare system after their health declines? And we just talked about how palliative care is sort of that insurance for folks before their healthcare declines. But let's talk about now about what happens after their health has declined already. Is there anything else that they can do to effectively navigate that healthcare system?
Yes, this is a really good question. I like this one. I would say the number one thing that people can do ahead of time while they're still well or able to have conversations is to start thinking about who would make decisions for them if they can't speak for themselves. So we call this concept a substitute decision maker, or you might have heard it referred to as a power of attorney for personal care. And in Ontario, we all have default substitute decision makers that are kind of listed by the government. Other provinces and territories have very similar substitute decision maker hierarchies. So there already is someone, or could be several people, depending on the hierarchy for you, appointed for you. I encourage everyone to take a look at that to know, who is it in my life? For many people, that might be their spouse, it could be their children, etc. And if the person who is the default, or the people who are the default, are not who you would want to make decisions for you, then that's when we encourage people to think about, okay, let's assign a power of attorney for personal care. I'm going to speak to Ontario here because I'm not totally sure about other provinces, but in Ontario, a power of attorney is a legal document, but it doesn't have to be done by a lawyer. So this is something that people can download the forms off the internet. They just need to get them witnessed properly. I can tell you it makes a world of difference in practice, because there are times I meet people who their substitute decision maker are all 10 of their children equally. And half the children don't get along, and half the children have been estranged, and nobody can agree on the decision. And then what happens there is we actually have to go beyond the children and move to the public guardian and trustee to make the decision, which I don't think is a situation that anyone wants to be in. So you can imagine many different family dynamics out there and why that can be difficult. And a power of attorney can be a really helpful intervention here. It's also important, whether you're using the substitute decision maker or whether you're using a power of attorney, to make sure you've spoken to that person or those people so that they know what's important to you. I have worked with many substitute decision makers and power of attorneys who, when the time comes for decision making, they say, we never actually talked about this. So I don't know what my mom would want. I don't know what she would pick for herself here. Sometimes the other thing that gets a little bit tricky with this is people think that these are conversations about treatments. And that tends to be a barrier into having these conversations early. I'm sure, Amanda, you can even think for yourself that if you went home tonight to speak to your family, it would be hard to think about, like, wow, am I going to tell them what I want? Chemotherapy? What if I'm never in a situation where I need chemotherapy? And so I say, don't actually think about it like treatments, because that's not really that helpful. You can never guess all the different possibilities of treatments that could be out there. Think about it more about the why or why not behind the decisions. So it's almost giving somebody that background in your mind about how you came to make the decisions. I'm going to give you an analogy for this because I know this is a little bit of an obtuse kind of concept to understand. So instead of thinking about healthcare, let's take a non-medical situation. So Amanda, you and I are going to go out for dinner, and I tell you, I'm running late. order for me. And you get to the restaurant and there's this whole menu and you realize, I have no idea what she likes or what she wants to eat. You're going to feel entirely overwhelmed to make a decision. And whatever you order, you're probably going to feel uncertain if that was the right choice. But if I'm running late and I say to you, order for me, and you know that I'm a vegetarian and I have an allergy to peanuts and that I really like fish, whatever it is, that with that information, you can go through the options and kind of rule some things out that you think, okay, I don't think she would like this, or, that's not an option. And that might more reasonably guide you to a decision that you think I might make for myself. And essentially, that kind of dynamic that we're talking about here is exactly the kind of conversations around advanced care planning. So it's not really, do you want a feeding tube or not? Or do you want CPR or not? It's actually about what in your life is important to you. What are the values or the activities that you couldn't live without? And being able to communicate that to your loved ones ahead of time. Okay, I've gone on a long rant about
that was
advanced care planning.
fantastic. No, that was great. That's a great summary of advanced care planning. And as a follow-up question on that subject, I want to ask about when you interact with patients or palliative care teams in that unit interact with patients. Roughly speaking, how many of your patients would you say have some form of advanced care directive completed, or have at least had some of those conversations about care, or assigning a substitute decision maker? How many folks would you say have at least done some of that or have that completed?
I hope when I get to the end of my career, I can tell you the answer to that is almost everyone.
Yes,
but right now,
us too.
right now, it's almost no one is the truth.
Wow.
As I would say, there are some people who have thought about those things and have had some conversations, but the majority of people I meet have not. So I do think this is a really big, almost a gift that you can give to your families, because I do notice a huge difference in terms of the difficulty of these conversations, as well as the experience for families when I meet people who, one, have had conversations and what that looks like versus families that have not. And it is a million times harder when no one has had the conversation before and you're living it all through the first time during a serious illness and a hospitalization. So it does make a big, big difference.
All right. Well, thank you. For any folks listening that haven't completed an advanced care directive, Dying with Dignity Canada actually does offer an advanced care planning kit that you can download from the website, or request to be issued to you in the post. So feel free to reach out and get that completed if you haven't done so already. All right. Thank you so much for that, Sarah. Let's go on to next question here. And this is about end-of-life care at home versus in hospital. Have any of your patients expressed a wish to receive palliative care at home as opposed to in hospital? If so, why? And can this wish be fulfilled?
So I have lived and worked on both sides of this equation, currently doing care in the hospital, but before this, I provided palliative care at home. And I definitely see the desire for care at home is something we talk about all the time in hospital. Everybody wants to know, can I go home? Is that an option? And what are my supports? And, I think when a lot of us picture what's important to us at end of life, the common things I hear are wanting to be comfortable, wanting to be surrounded by people I love. And for many of us, that kind of feeling evokes the sensation of being at home, right? That there's no place like home. There's been lots of research looking at this too. And I think the most recent stats when they've surveyed Canadians is that most Canadians say they do want to die at home. So no doubt we all see the appeal. And if it's an option, depending on where somebody is in their illness trajectory and what supports are available to them, what does home look like for them, what are their social supports, what are the resources we can put in place, we certainly do everything we can to make that a possibility. But I will say that we work in an imperfect system, and it is not always easy to get enough resources to care for people adequately at home. The other factor, and something we think about a lot in hospital, is that the time it takes to put resources in home can also be a big factor. So sometimes I meet people and they tell me, we really want to go home for end of life care. and I'm looking at their mom, and I'm worried we're talking about hours or days of time left. And I know that in order to get things put in at home, like getting a hospital bed, getting nurses to come out to the house, I need at least 24 hours, if not in many places, more than that. And so sometimes it's like a race against the clock here. So I encourage anybody who's in hospital, who's thinking, that's kind of the direction I want my care to go, to express those wishes early. I know sometimes people worry, oh, it's too early, or we're not there yet, or we're not thinking about discharge planning. There's kind of a reason why the moment you get into hospital, everybody becomes obsessed about talking with discharge planning right from the second you're there, is because things take so long to put in place that we want to make sure we don't miss those windows of opportunity. That if going home is the end goal here, tell us early. Even if it's not time yet, that just helps us, okay, that's good to know. We'll put that thought on the back burner. And then when we're ready to start planning, we know what your wishes are. Because sometimes if we wait too late, then we don't have enough time.
Thank you for that. And as a follow-up question, I'm just wondering if we can go into a bit of the specifics of what are some of the things that somebody might need to think of if they're, again, planning to receive end-of-life care, palliative care at home. Things like transportation, or as you mentioned, getting a hospital bed put in, or having a nurse come to visit, that sort of thing. Wondering if you can just delve into some more of the
Yeah.
specifics for folks that haven't been in hospital care just yet and might need to think of this in advance.
So there's lots of different things I would think about here. So I'm going to first kind of think about the physical care needs. So that's things like who's going to help with dressing, with changing, with showering. And this will depend on what somebody's functional status is. So sometimes people are well enough that they're still able to do that themselves, and they might be starting to need a bit of help, but we're planning for a future that in the next coming months or weeks or even shorter amount of time, your function's going to change. So we need to be prepared that even though you can manage that right now, what happens in a couple weeks from now where that becomes more difficult? We work a lot with home care agencies about what resources are in the community that we can put into place. So home care has nursing support, and they have personal support workers, occupational therapists, physiotherapists, who can all go into the home to help optimize that physical care. But unfortunately, nothing in the community is 24/7, right? That's coming into your own home. And so when I meet patients who live alone, this becomes a really big factor that we need to think about, right? That if you're by yourself at home, what's going to happen if you need something when you're alone? And sometimes that means bringing in additional private supports. Sometimes people have family situations that might be flexible, where if we're talking about a shorter amount of time, and I see this more so in cancer trajectories where we have a much better ability to predict or prognosticate how much time somebody has left, where families will really rally to say, how do we manage care for mom at home for the last couple months? And someone might take a leave from work and someone might move in, and they can make those adjustments to their life for a short period of time to optimize that family support in the home. But in our non-malignant diagnoses, this is a lot harder because the ability for us to actually put a number on how much time is much more difficult. So in cancer, where I can say, with some degree of certainty, I think we're in the final weeks to months of time. When I meet people who have heart failure, renal failure, liver disease, it's much less certain. So you might be able to say, you know what, I could get a leave of absence from work for a couple months, to help. But could you do it for a couple years if that's how long it is? And most of us are not in that kind of situation. And where I see this the most challenging, at least in the population in the area I work in, is with dementia. Dementia has a very, very long trajectory. And I find most families cannot accommodate the amount of care needs that people will have for that long amount of time. So if people are lucky enough to have the financial resources, this is where I often see people bringing in private caregivers. But if not, this is when we start getting into conversations like, what are our other living options? Retirement homes, assisted living, long-term care environments that will be able to provide that additional physical care for a longer period of time. So that's kind of the physical piece around needs for people to think about. There's also kind of tied in with that things about accessibility. So whether that's equipment being brought into the home, people kind of immediately think about hospital beds, which are an option to bring into the home. But there's also lots of other things like elevated toilet seats, grab bars in the shower, little transport walkers, things that if you're still able to get out of the house, how can we do that in a way that's safe, that optimizes energy conservation? If you need to still get to appointments, is that feasible? Are you able to transfer into a car and get to a clinic for an appointment? And if not, then we need to start thinking about alternatives. And that kind of ties into the second piece, which is the medical piece of care. So some people are very lucky to have family doctors who do home visits, but that becomes fewer and farther between the more I am into my career, that I'm not seeing that quite as much. And so we're always looking at who's going to manage your medical care, who's going to be there to, provide medication if you have new symptoms, or who's going to order that medication. The nurses from home care are a huge part of this, who are in the home to do the assessment, who can communicate with somebody who's ordering it, but you need to have a prescriber involved. And this is where the limitations of sometimes people say to me, well, I have a lot of financial resources, which is great. I can pay for things, but the one thing you can't actually pay for is having a doctor or nurse practitioner in your care.
Yes.
And so this is where home visiting palliative care teams really come into play here. Home visiting family physicians, nurse practitioners in the community all play huge roles in providing this kind of care.
Wow, thank you so much for that comprehensive answer covering the physical and medical considerations when transitioning from in-hospital to home care. Let's talk about now, so we've talked about situations where a patient might be able to transition to home care. Let's talk about situations where a patient can't transition. So question, when a patient that wishes to receive care at home cannot, due to their conditions, how can a hospital make the experience more comfortable and more accommodating?
Mm-hmm. So I mentioned that stat, how most Canadians say they want to die at home. And we know that most Canadians do not die at home. The majority are still dying in acute care or other facilities. And kind of more interesting piece to that is when you ask families of those people who died, did your loved one die in the place they wanted to die? The majority actually say yes. So there is some kind of disconnect between earlier on when we're well, we might think we want to die at home, but that after, even for people who are dying in hospital, families are still saying that was the right place for them to be. So I think there is a bit of a romanticized version of what dying at home looks like, and that people never really know how they're going to handle the situation until they're in it. And sometimes people think that that's the plan they want, and then situations unfold, people's symptom changes, their functions change, supports change, and they might be feeling like, actually, end of life care at home is not what I want, or isn't what feels safe. And then we're looking at other plans. Or I gave you the situation earlier that sometimes people are in hospital and it's actually just not safe to transfer them out. That the amount of care needs they have or the amount of time we're talking about really prohibits us from leaving the current environment of where they're at. And so our goal is really to optimize comfort in any way we can in the hospital, bringing in those little pieces of home to make it feel essentially as cozy as it can be. And it might sound a little bit silly, but even things like the power of a pillow and a blanket from home make a big difference. I've had families decorate the rooms in the hospital, putting up pictures. A recent patient I had, their family brought in a lamp, which I know sounds, people wouldn't think bringing in a lamp to the hospital, but I can tell you it made such a difference because we no longer had to use that awful fluorescent overhead light.
Yes.
And we turned on the bedside lamp, and it was really such a nice little touch that made it feel so much cozier. Things like families will bring in CD players. That probably dates me. Nobody uses CD players anymore.
That's okay. I know what you're talking about.
Yeah. Bring in CD players so people have music playing. Like there are lots of little things that we can do that really can make it feel as much as home as we can. But more than any of the things is the people, right? And I think that's ultimately what home is. Home isn't so much a place, it's about the people you love and having them with you. And so, to the very best we can, optimizing family and caregivers' presence at the bedside and visiting is the number one priority. And I know over the last 3 years, this has been really, really hard. That COVID has, had a huge impact on this part of end of life. And it has been, very, very detrimental to anyone who experienced end of life care during that time. And even for all the hospital staff who were part of this, who watched something that was so essential to us be taken away. I think we are really trying to come back from that and get back that piece of normal that we had before. And so making sure families are present is really, really important to us.
Thank you for that. And as a quick follow-up here for making the experience more comfortable and accommodating, for patients or for loved ones, who do they go to ask for those kinds of accommodations, or how do they bring up that conversation?
I always say start with your primary nurse when you're in the hospital, because that's your main point of contact to talk to the nursing team. And if they can't answer your question, to go to, there's usually a charge nurse or a unit coordinator, or to speak to the unit manager to talk about how do we put in a care plan for you. So I think number one thing to do is just ask, right? To know, what are my options? What does the visitor policy look like? And if the situation doesn't feel right to you, to just keep asking questions with your healthcare team to try to come to an agreement that works for everyone.
All right, thank you so much. So that's the end of our formal interview questions. So thank you so much, Sarah. We're now going to move on to audience Q&A. And before we get started, I do just want to do a call back to that podcast that you mentioned, the publication Hope for the Best, Plan for the Rest. As it turns out, the GTA chapter for DWDC is going to be hosting an event on April 16th with the authors for that publication. So information for that is going to be shared in early March. So for those in the Toronto area and nearby, please stay tuned for that notice. So thank you so much for that plug as well, Sarah.
I didn't even know that. So how topical.
Perfect timing, perfect connection. All right. So thank you so much to our audience members for submitting these questions in registration and during the session today. Let's start off with a question about palliative care. So this audience member asks, you spoke about palliative care being about symptom management, education on disease and illness, and that people often think that palliative care is end-of-life specific. Can you explain the difference between hospice and palliative care?
So palliative care has to take some of the blame here, that we are not doing ourselves any favors with our language. It is so confusing. We use the term hospice and palliative care sometimes to be this quite broad umbrella term. So the umbrella term meaning as approach to quality of life at any stage in somebody's illness. But then in how we actually implement palliative care looks different at different stages and also has different criteria. So it might be a little bit confusing because I'm here saying palliative care is for everyone. And you might be in a situation where you say, well, hold up. I tried to go to a palliative care unit and they told us you're not eligible. So how are those things true? And this is where I say we're not doing ourselves any favors with this because we're making it very confusing. So while hospice palliative care as an umbrella term, there is something called hospice, which is a little bit different. And even within hospice, there are multiple definitions. So again, very complicated. There are residential hospices, which are places that provide end-of-life care. And typically hospice provides care. Now, again, I'm giving from an Ontario lens, so you might be from a different province or territory and have something slightly different. But in Ontario, when we think about hospices, these are usually places that are providing care in that final weeks to month of time. So a very short period. There are also hospice organizations that provide support, resources. A lot of them have bereavement programs, they have support groups, and they're there, again, more similar to palliative care definition kind of all throughout somebody's illness trajectory. So I do find there are hospice volunteers who go into people's homes, even when they have many months or even years left to live, and help provide that kind of support, education, working with children, things, many different services like that. So kind of two different kinds of hospice. I hope that kind of answers your question. I know clear as mud about the language.
Well, I appreciate you tackling it. To ask a follow-up question here about grief and bereavement, I wanted to ask just in the broader context of when you provide consults or you provide advice to patients and loved ones, do you experience grief in terms of with the patients and loved ones that you care for? What kind of care do you connect patients and their loved ones with, or what types of disciplines or specialists?
Yeah, a lot of us tend to think of grief as the feelings after somebody dies, but grief is actually much larger than that. If you had to define grief, it's really about the experience of loss. And a loss doesn't have to be a death. That loss can be the anticipatory death of somebody, but it can also be the loss of what I'm going to call the day-to-day normal. Think of what it's like when somebody in your life gets diagnosed with a serious illness, and everything changes. How they see themselves might change, their own identity, if they're able to work, the role they have in the house. There's this huge shift that happens, and that itself is a loss, and there is a lot of grief associated with that. So I find when I meet families, when I meet patients at any stage in their illness, I'm encountering them at different stages of loss and grief. And so there's a lot of work that we do all throughout that. And there's also a lot of anticipatory planning we do for the bereavement period or the period after somebody dies. So I try to connect people who I think are most risk with resources ahead of time, or letting them know a little bit of a roadmap of what to expect here. I don't recommend kind of grief and bereavement support in that immediate weeks to short months after somebody dies, because you need a little bit of space from the loss to be able to process it. Often grief support occurs in support group settings, or at least in Ontario, again, and you have to be in a place where you're comfortable with other people and sharing stories about that loss and hearing stories about other people's loss. And so I do find that there is a too soon for this. It is helpful to have a little bit of space. And the unfortunate part of that is that I'm meeting you before this loss has happened and trying to recommend a support that I think is good for you to think about maybe in a year from now. So a lot of what I'm doing is giving people information and giving them who to connect with. And this is where people's primary care providers, their family doctors, their nurse practitioners play a huge role in connecting people to grief and bereavement support. And that's where I always encourage families that if down the road from a loss, if you are 6 months, a year out and feeling like I just can't kind of wrap my head around it or kind of get back to some kind of normalcy, I encourage you to reach out to your primary care providers to talk about what are the options in your area for grief and bereavement support to connect with somebody.
All right, thank you so much for that. And thanks to our audience member for that question. Next question here. Palliative care is often, as we just mentioned, associated with death and dying or the end of life. Can you explain a bit more about why someone ought to or would access palliative care?
Good question.
Our audience is smart.
I'm going to tell you a little bit about the history of palliative care. So this is still a relatively new specialty that came out of the, let's say, 1960s, because of this gap in care where people felt like they were abandoned at the end of life, that there was no more treatments or nothing left to do. And so kind of you're on your own. And palliative and hospice care came in to fill this void, to say, I'm going to quote Cicely Saunders, because I'm a palliative care clinician, who basically came to say, you matter your whole life, and we are going to take care of you until the very end. But then we started doing a lot of research on palliative care. Once we came and filled that void and really established ourselves at end-of-life care, we started saying, do people's symptoms only matter at the end of life when you're dying? Why is it that in that final month or week or however much time, sometimes days or even hours in hospital, we come in and now we say, gosh, we got to make sure that their pain is under control, that their breathing is comfortable, make sure the family's here. And I think, well, actually, that was important all throughout their illness. That shouldn't just be important at the end. And so over the last 30 years, there's been a ton of research looking at this. What are the benefits of early integration of palliative care? And what the research finds is the earlier people meet palliative care or have a palliative approach integrated into the care, the more time they have to have these conversations about what matters most, the more time they have to prepare for what's to come. And so we find people report higher levels of control or autonomy. They report lower levels of anxiety, lower levels of depression, lower levels of stress. And there's really kind of that better satisfaction with care. So that tends to be the main reason why people seek palliative care early on. And it might not be the person recognizing, oh, I need palliative care, but they might be saying to their healthcare provider, you know, this pain is terrible and I just can't get this pain under control. And their healthcare team might say to you, I'm going to refer you to a specialist to help with this. And sometimes palliative care goes by different names. So you might hear us referred to as pain and symptom management clinics or pain clinics, or you might hear you're going to be referred to the supportive care team. And if you ask, those are usually palliative care trained providers who are specialists in symptom management and also experts in helping people navigate difficult journeys and making difficult treatment decisions for themselves.
All right. Thank you so much for that. And thanks to our audience member for that question. As a follow-up question for national or for resources for reaching out to seek palliative or hospice care, do you know of any national or provincial resources that could be helpful for someone seeking out palliative or hospice care information, or who could you start with to ask these kinds of questions?
So I really like Canadian Virtual Hospice as a website for providing information. They've got a place where you can actually put questions in. So it's really good for the content, so to speak. But in terms of knowing who are your actual supports, who are the teams, or who's the clinic you could be referred to, who's the home visiting team that could see you, this is a really complicated question, I should say there is no good answer to this, unfortunately, that at least in Ontario, and I know some provinces are better than us at doing this, we do not have a cohesive system about what the resources are. So the best thing to do is actually be able to speak to another provider. So whether that's kind of your primary care that you're going to say, hey, what are the palliative resources in this area and available to me with my disease, etc. That is probably your best place to start to get the most tailored options for you. Because I do find you can go down quite a rabbit hole when you start Googling what are the palliative resources around me, and not everything you find there is accurate or not so easy to kind of understand either.
All right, thank you for that. And thanks to our audience member. Let's talk now about, again, palliative care. This audience member asks, what are the greatest successes and what are the greatest downfalls or shortcomings, if you will, of palliative hospice care?
That's a great question. I think the greatest successes are when we can provide patients and families those opportunities for connection during some really dark times. People often ask me, how do you do this work? Like, I can't imagine doing it. It must be so sad and depressing. And it's not that the work isn't sad, but I think there are lots of things in our life that are sad, but are still very meaningful and important to do. And I'm going to give an example that actually is quite sad, but was a very touching moment for me, that I had a young woman who was dying of cancer. And it had been really, really hard for her to talk about future planning with her family. This just wasn't something she was able to engage with. And she had a very young child at home who was a year old. And her family really wanted to be able to do some legacy work so that her child would have something to remember her. but she wasn't able to engage in that it was too difficult for her. But when she was dying at the end of her life and when she was in hospital, and the family came to us with, what can we do to help remember her after that her son can remember her by? And the team in hospital did an incredible job of doing some legacy work with the family. And they ultimately recorded her heartbeat and they put it into a bear that her son would have. And I thought that was a really nice way to give something back to this family. And I know it's an incredibly difficult situation, but a little piece of mom that baby will have forever. So I think, that's kind of the first example that came to my mind of what is success to me in palliative care, is those moments. And what are the hard parts? There are many hard parts about this work. And I think when I'm encountered with a system that doesn't support us the way I want it to, or when I see the failures of, not only the healthcare system, but in the greater system that we live in, and people who fall through the cracks, or, we've talked a lot about this idea of end-of-life care at home, which is great if you have a home. But there are many Canadians that do not have a home the same way we think of. And we don't have a system that really adequately supports people for that. And not at end of life, but also not throughout their whole life in general. So I think being in work like this allows you to get very close to people and really see the details of somebody's life and the journey. And it also exposes a lot of the inequities in our society. And I think that's the hardest part for me.
Thank you so much for sharing and for sharing that beautiful story about that patient that you were able to support as well. I want to follow on that thread of shortcomings, so to speak, or when patients don't have equal access. And I want to talk more about patients that are in hospital receiving palliative or end of life care, but don't necessarily have access to a family doctor, don't have access to loved ones, or in connection with loved ones or anybody that can support them, and are essentially isolated at that time. What other resources or what other strategies might your hospital take or palliative care takes to support those folks that are more isolated than your average quote unquote patient might be?
Yeah, that's a really good question. And this is where it goes back to palliative care as a team. And this work could not be done without palliative care social workers, who play a huge role in navigating some of these really, really difficult situations. And what do we do for that? So again, there's kind of no one size fits all approach to this. It's very individual. But social workers are an incredible resource who are able to help us navigate an imperfect situation or an imperfect system to find what is the best option that we have for people. And I think as a whole, palliative care clinicians are often really good at more than just the tick box or the criteria, really good at looking at the patient and family situation and making individualized recommendations and care plans. So, for example, sometimes we have some like really rigid criteria around who can get into, I'll use hospice as an example. But I think we also recognize that there are rules that we have kind of for the majority, but then there's also exceptional circumstances where we say, you know what, it might not 100% fit criteria, but for reasons X, Y, and Z, this is the most appropriate place for this person to be because they don't have access to whether it's housing or whether it's the right supports. And how do we make sure that everybody has dignity at the end of life?
Thank you for that. All right, next question here. And this audience member would like to ask, is it possible to request for a change in physician or clinician if the patient feels that their end-of-life wishes are not being respected? Has something like this ever happened before or been requested before?
Yeah, great question. So I would say in general, yes. I've certainly seen this situation in my practice before, But I will say that the hospital system is often very complicated and sometimes challenging to navigate through. So it may not always be possible. I think it's always okay to ask and to share your feedback with the team, because they won't know if it's not the right fit or if things aren't working unless you share that feedback. But there are some situations where it might not be possible to change the doctor. I'll give you a very specific example. If you are in the ICU, there is only one of that specialized doctor who is looking after all the patients in the ICU at a time. And so there isn't any other doctor who meets that same qualifications to look after you. So that would be a situation where they say, we hear your feedback, but there isn't another option for someone who can take care of you based on your current care needs. But outside of kind of more specialized environments, it sometimes can be an option. So I do think it's important that you kind of give that feedback and share what isn't working.
All right. Thank you so much for that. And thanks to our audience member. For next question, are there any costs associated with receiving palliative or end-of-life care in hospital, just sort of within the hospital itself in terms of medical care and treatments, but are there any costs that others should think of while receiving care in hospital?
Mm-hmm. So in general, there are not costs associated with receiving palliative care. Now, I will say the exception to this in hospital is really around accommodations of rooms. So often people will tell me I want to be in a private room or a semi-private room, and there is a cost associated with requesting those specific rooms, which many people's insurance can provide coverage with. So that would be kind of the main aspect in hospital where you might find a cost is about rooms. In the community or in like a palliative care unit, the palliative care unit is covered by our healthcare system. I'm trying to think of other costs. Home visiting teams or coming into a clinic, those are also covered by the healthcare system. But it's the things that the team might be recommending to you that might not be covered. So the best example here is outside of hospital is medications, right? That we actually don't have a national pharmacare plan that's covering everybody's drugs. And there are certain drugs that are more expensive than others. So your doctor might be recommending, I think medication X could be a good drug for you, but medication X could be very expensive if you don't have any drug coverage. So those tend to be medications, equipment, things like that, the caregiver support. So if you are hiring additional supports like additional personal support workers, those are the things that come with the cost, but the actual physician, nurses involved in the care do not.
All right. Thank you so much for that. And thanks to our audience member. This audience member asks, you mentioned that clinical nurse specialists have a specialty of some sort, with yours being palliative care. What are some of the other specialties that someone may choose, if you can name any off the top of your head?
Yeah. One of the most common ones for clinical nurse specialists that you'll encounter is emergency medicine. So in the emergency department, there are many clinical nurse specialists. They often go by a different title than clinical nurse specialists, just because our system chooses not to be straightforward like that. So they are often called GEM nurses, GEM, which stands for Geriatric Emergency Medicine. And these are clinical nurse specialists who have expertise in geriatrics and emergency care. That tends to be a big role. You'll also find them in places like oncology, cardiology, nephrology. I'm trying to think of, I find them a lot in surgery floors. So they can also go by a different job title here. Patient navigator tends to be one that is also a clinical nurse specialist. You'll meet a lot of patient navigators in the oncology world. So breast cancer, colorectal cancer tend to be very big programs that often have navigators involved with them, as well as hip and knee surgery tends to use navigators a lot. So those are some of the top examples I can think of, at least from my experience in Ontario.
That's wonderful. Thank you. All right, next question. And I'm not sure if you might have expertise on this, so feel free to comment otherwise. This audience member asks, how can I request medical assistance in dying as an end-of-life option in hospital? Do you have any experience with MAID requests or information sharing?
Yes. So this is a big part of end of life in general, medical assistance in dying. And I know Dying with Dignity has done many great webinars about this topic. So there's a lot of really good resources out there if you're looking for, am I eligible? What's involved in the process? So I won't kind of speak to that today. But I think the most important thing is you have to tell somebody, right? That nobody knows that you're thinking about this or that you're interested or want to know what your options are if you don't tell somebody. So talk to the primary healthcare provider that's working with you and let them know either, hey, this is something I've been thinking about, or maybe you've already put in, like, done the first piece of paperwork for it and you are just deciding on a date. But we actually don't know that because, again, in Ontario, we don't have any kind of centralized housing for documents. So when you come into hospital, you could be halfway through the MAID process, but I won't know it all unless you tell me about it. So definitely communicating that with your healthcare team. Now, every hospital does something different for medical assistance in dying. In my hospital, it's the ethics team who is the one who kind of coordinates that or meets the person to give information if they're just looking to learn more about it. Many other hospitals are starting to build what they call medical assistance in dying teams. So meaning you might say to your doctor, hey, this is something I'm interested in. And they'll say, I'm going to put a consult into the MAID team. And usually it's a team full of nurses and physicians who then might come to you and kind of speak more about what the process is, eligibility, and help walk you through that. There are many different options for MAID in hospital, and it depends really on what you're looking for. So sometimes people say to me, I'm ready now. That as soon as you give me the go, I'm ready to go ahead with the procedure. And if that's the case, and with the new changes to medical assistance in dying, that is something that can often be facilitated, meaning that people can apply for the process, get assessed, and have medical assistance in dying during that hospital admission. I've also had many other people say to me, this is something I want to start thinking about and putting plans in place and getting my assessments done, but I don't quite have a date just yet. Or I'm thinking I want to have it when I'm at home. And that's also an option too. So sometimes the process can be started in hospital and then finished in the community. That again is going to depend very specifically on your local resources, because sometimes people might say to you, actually, it makes more sense if you want it at home that we connect you with the people in the community who are going to be the assessors and providers. So a little bit of nuance there. And then there's also now the Track 2 stream, which again, I don't want to get too much into the details here, but essentially for people who do not have a foreseeable death, who might have quite a longer waiting period for their assessment, things can be started in hospital and then followed up in the community. So I hope that answers a little bit of the question about MAID.
Thank you so much. We're going to switch gears a little bit with this next audience question. This audience member asks, what do you do if you have no family or no close people that you could assign as a substitute decision maker? Who do you provide something like a completed advanced care directive to that will honor your wishes, besides retaining someone like a lawyer, for example?
Yeah, so this is where a power of attorney can be used to appoint even a friend or a neighbor or anyone in your life. It doesn't have to be a blood relative. I have seen, I know they said other than a lawyer, but I have had people who don't have anybody left, that unfortunately all their loved ones and close family or friends have passed and who have gone to a lawyer. And this is where a legal document beyond a power of attorney is probably very helpful here. Each province does their own or has their own rules in terms of advanced directives and living wills and what those terms are and what is legally binding. But even if the document is not legally binding, it can still play a very big role. Do I have time to give you a little case situation here, Amanda?
We've got just about 10 minutes left. So
Okay.
definitely
I'll give
go
you a
into it
very
because I think
short
it's a
one.
valuable answer. Go ahead.
That's because in Ontario, living wills are not legal, meaning that, or legally binding in the way that you can put in your living will, I don't want XYZ, but ultimately that document cannot be used for consent. It is your power of attorney or substitute decision maker who's going to be the one making the decisions for you. But they can use that document to help guide their decision. And I'll give you this example where I encountered somebody in hospital. Her husband had suffered a very significant stroke and he was dying. And we were consulted to see, would he want a feeding tube? How interventional should we be for the next stage of his care? And his wife was really struggling with the idea of not putting a feeding tube in. She said, even though I do not think he would choose this for himself, I never had this conversation with him. And I don't know if I can live with the guilt of possibly not taking something that he might have chosen for himself. And so we left the conversation that likely she would proceed with putting the feeding tube in. And I met with her the next day and she said, I went home after our conversation and I found his will. And in his will, he actually outlined things like, in the event of a serious illness, I would not want any life-prolonging interventions. I would not want resuscitation. I don't want IV fluids. I don't want feeding tubes. And she said, this document gave me the permission to do what I know he would want. And so I think, well, there was a perfect example. Well, no, that document isn't legal and it's ultimately the wife's choice, but it made such a difference to her to almost be able to hear it in his own words, right? Even though he couldn't speak to her anymore. So I still encourage people that if you don't have a lot of family support or you don't have anyone to appoint, what is impactful about a living will is that if the decision maker becomes public guardian and trustee, they will look for any of your previous expressed wishes. So that's where it can be helpful there, because sometimes we don't have anybody in our life that we can appoint.
Absolutely. Thank you for that. All right, we've got a few more minutes here. Let's see what we can get through. This audience member asks, can you share your experience with end-of-life doulas involved in palliative care? Have you ever interacted with death doulas or with a patient that's retained the services of a death doula?
I haven't directly. I am hoping to. So if there's any death doulas in the audience, please call me. It is something that is certainly becoming more of a trend. So I do expect over the next kind of 10 years or so that we'll see a lot more of this. But I have heard of it through, friends of friends, that they're starting to see this more in communities they work in. So for anyone who doesn't know, death doulas are almost like patient navigators in a sense. They are experts in end of life. Many death doulas have nursing backgrounds, but that's not necessarily a requirement. But it is someone who is essentially going to be an advocate for you, who will help guide you through the journey, help connect you to resources, and help you navigate through the system. So they can be very helpful. The challenge is, of course, that doulas are not part of the healthcare system, so they are not publicly covered, meaning this is a private service that people pay for. So again, this kind of goes back to the issues with equity in our system, is that I think everybody deserves the right for help navigating the system, but this is not something that's publicly covered. But it is a very interesting area of medicine. I would love to learn more about doulas.
All right, thank you for that. And thank you so much for that audience question, likely a death doula as well. So thank you for your hard work. Next question, this audience member asks, there can often be long wait times for long-term care. Do you know of a triage process in those spaces for people with immediate needs? Or are you able to triage for patients in hospital that need to be transitioned to long-term care, for example?
Long-term care is a huge issue in Ontario in terms of wait times. I don't know if the other provinces are experiencing something similar to here, but I know I have personal experience with this. We are talking about many, many years and sometimes longer for specific long-term care homes, which ultimately just isn't all that practical for most people's journeys, because it is very hard to say, I know I'm going to need long-term care in 10 years from now, and that the bed is going to become available exactly when I need it. And this goes back to this imperfect system that long-term care and how the wait lists work just never quite adequately matches the needs, or I should say in general. For some people, magic happens and the timing lines up. Home care in Ontario is the one that organizes the applications and the waits. And so communicating with that home care coordinator who is helping you go through the process, because different homes have different wait lists. And sometimes there's a plan A of, at this point in time, this is what we're hoping for. We're going to apply to these homes. But then maybe a year from now, things are changing. And we are on a wait list that is a 5-year wait list. That's maybe not so realistic anymore. And so being willing to kind of change the plan, move to plan B, maybe that means applying to different homes, seeing what the options are. This is often when discussions about assisted living, retirement homes come into play. Again, those are not publicly funded places. They are all private. So there's quite a cost associated with that too. Home care might be able to put in extra supports to help bridge if we're thinking that the wait list can be shorter. There's also things called crisis wait lists for long-term care, which is a whole separate process and something that I'm not the expert in, so I won't speak to. But unfortunately in hospital, I do see this quite a bit, that I have many patients who come into the hospital because they simply were not safe at home anymore, that they're waiting for long-term care and their care needs are more than what can safely be met at home. And so I say it's never wrong to come into hospital if you are unsafe, right? We don't want anyone to be failing at home. And while acute care is not the best place to be waiting for long-term care, sometimes you need that kind of expertise and support to get things sorted, to get a new plan in place. And then the teams will do their best to find out what is the safest option for you to go while we wait for long-term care.
All right. Thank you so much. I think we're going to wrap up with one final question with the time we have here. Let's take a look. A quick question here. If you're having or you're receiving palliative care at home, can a nurse practitioner prescribe medication, or do you need to have a physician visit your home?
Great question. Nurse practitioner can be the one prescribing. Nurse practitioners, and I'm an NP student myself, so
Yes.
nurse practitioner's scope of practice is huge, and it has changed a lot over the last 10 years. I was just talking with a nurse practitioner yesterday who said to me, she had a patient ask her, well, what exactly can a nurse practitioner prescribe, or what can they not prescribe? And in Ontario, basically the short answer is, she said to her, the only thing I can't prescribe for you is heroin, and everything else is on the table. So essentially it is very similar scope of practice in the setting of home visiting palliative care. So many people in the community will have a palliative nurse practitioner who's the primary one looking after them.
Wonderful. Thank you so much. And you know what? That was a quick answer. So let's do one more final question. Let's see here. Oh, this is a great question to end on here. So this audience member is asking about you specifically and your healthcare team. What do you and your team do for self-care?
That's such a nice question. We are a team that loves to eat.
I love it.
We have regular team meetings, and it has been my thing that I organize a potluck at every team meeting. So this is a great way for us to feed each other, take care of each other that way. It's also how we celebrate the small victories. Also things like people's birthdays and people getting married and having babies. And I think really just making sure that, work is also a family. We spend a lot of time at work. Sadly, I spend more time with my colleagues than with my own family. So I think it's important that we get to know each other and we spend that time talking that is separate from work, and take care of each other. When we know somebody has had a really hard case or a hard day, doing that little extra thing to look out for them, or making sure that okay, this was a very difficult case that, so-and-so dealt with. Let's make sure we're going to give them a slightly easier case the next time, just to give themselves a little bit of time to reflect.
All right. Thank you so much. Short and sweet, and we also do office potlucks as well. So good to hear we're not alone in that. All right, folks. So unfortunately, we're out of time today. Sarah, thank you so much for joining us
Thank
today.
you.
This was wonderful and informative. And to everybody joining us, thank you so much for attending and for submitting your questions and registration and throughout the session. Webinars like this one and all of our other compassionate services are provided free of charge to Canadians navigating their end of life, their loved ones, and their healthcare providers. To enable us to continue providing these services, we ask that you please consider making a charitable donation. We'll be putting the links in the chat for anybody that would like to consider donating. And lastly, once again, Sarah, thank you so much for joining us. Thank you so much to our audience members, and I wish you all a pleasant afternoon.
Thank you so much for having me.
Thank you. It was a pleasure. Bye, everyone.